Hey everyone, welcome back. If you're a med student, resident, or just someone deep diving into immunology and rheumatology, this one's for you. Today we're reviewing Skyrizi, also known as Risankizumab, a biologic that targets IL-23. We'll cover the science, the clinical trials, and where it fits in real-world practice, from psoriasis to psoriatic arthritis and even Crohn's. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. Skyrizi is a humanized IgG1 monoclonal antibody that selectively targets the P19 subunit of interleukin-23, IL-23. It's part of a newer generation of biologics that aim for narrower cytokine blockade to reduce inflammation without broadly suppressing the immune system. IL-23 is part of the IL-23-Th17 axis, which is central in the pathogenesis of psoriasis, PsA, and IBD. Blocking IL-23 decreases downstream Th17 responses, including IL-17 production, neutrophilic infiltration, and keratinocyte activation. Skyrizi differs from agents like Ustekinumab, which targets the shared P40 subunit of both IL-12 and IL-23. By isolating IL-23 inhibition, Skyrizi may offer fewer infections and more specific immune modulation. Skyrizi approved for moderate to severe plaque psoriasis, 2019, active psoriatic arthritis, 2022, moderate to severe Crohn's disease, 2022. Off-label discussion is starting around potential roles in axial spondyloarthritis, but IL-23 blockade has not yet shown clear efficacy in ankylosing spondylitis, unlike IL-17 or TNF inhibition. The regimen depends on indication. For psoriasis, 150 mg SC at weeks 0 and 4, then every 12 weeks. For psoriatic arthritis, same initial loading, then every 8 weeks. For Crohn's, a 4 induction at weeks 0, 4, and 8, followed by SC maintenance every 8 weeks. It's self-administered subcutaneously, except IV for Crohn's induction, which patients appreciate for convenience, especially compared to more frequent dosing with older biologics. In the ULTEMA-1 and ULTEMA-2 trials, J-Med 2019, Risankizumab outperformed Ustekinumab and placebo in achieving PASI 90 and PASI 100 responses. At week 16, 75–80% achieved PASI 90. Nearly 40% achieved complete skin clearance, PASI 100. In SA, the keepsake trials showed significant improvement in ACR20 responses with additional benefit in dactylitis and enthesitis domains. For Crohn's, the Advance and Motivate trials showed 45% of patients achieved clinical remission at 12 weeks. Endoscopic response was seen in 40%, with mucosal healing improving over time with continued maintenance. That places it competitively among other advanced therapies, though head-to-head data with Ustekinumab or IL-17 inhibitors is still emerging. Risankizumab has a favorable safety profile. Most common AEs, nasopharyngitis, fatigue. Serious infections are rare, but TB screening is still mandatory prior to initiation. Long-term data, 5 years in psoriasis, shows low immunogenicity and no clear signal of malignancy or serious opportunistic infections so far. Since IL-23 blockade doesn't broadly suppress TNF or IL-12 pathways, risk of reactivation of latent infections may be lower than older agents, though vigilance is still key. So how does Skyrizi compare to other biologics? Compared to TNF inhibitors like adalimumab, Skyrizi may outperform in skin clearance, but may be slightly less effective in joint and axial symptoms. Compared to IL-17 inhibitors, like secukinumab or ixekizumab, Skyrizi is less effective for axial SPA but may have lower candidiasis risk and better injection interval. Compared to ustekinumab, Skyrizi provides more complete IL-23 blockade and seems to deliver higher PASI response rates. It's becoming a go-to for plaque psoriasis and a strong option in skin-dominant PsA, but in patients with spinal involvement, a TNF or IL-17 blocker may be preferred. From a clinician's perspective, ideal candidates for Skyrizi include patients with moderate-severe psoriasis who want long dosing intervals, PsA patients with predominant skin disease and less axial disease, patients who failed or didn't tolerate TNF or IL-17 inhibitors. In IBD, it's considered for patients with moderate to severe Crohn's, especially those who've lost response to anti-TNF therapy. For med students, always consider the phenotype of the disease, the mechanism of the drug, and the risk-benefit profile before choosing therapy. To wrap up, Skyrizi is a selective IL-23 inhibitor that's highly effective in psoriasis, psoriatic arthritis, and Crohn's disease, with a clean safety profile and infrequent dosing. It represents the ongoing shift in immunology toward precision cytokine targeting, and as we get more head-to-head trials and real-world data, its role will become even more defined. If you're in med school or residency, keep an eye on this drug. It's becoming a mainstay in both dermatology and rheumatology. If you found this helpful, drop a comment, hit that subscribe button, and check out our playlist on Biologics in autoimmune disease. Want to break down on IL-17 blockers next? Let me know below. See you next time.